So the first case is a urine cytology, and the patient has past history of high-grade urothelial carcinoma. So on low power, we see this loosely cohesive urothelial cell with markedly enlarged nucleus comparing to the adjacent normal inflammatory cells. In addition, this cell shows some degeneration as well as nuclear polymorphism and hyperchromasia. We can also see some scatter cell with more preserved nuclear and chromatin, but with very, very high NC ratio. There were also some scattered, very bizarre cells. Despite the low NC ratio, you can definitely see the nucleus is not normal. It is also a malignant cells. So these ones as well. So this specimen is definitely positive for high-grade urothelial carcinoma. The second specimen is also coming from a patient with no history of high-grade urothelial carcinoma. So on low power, we can also see similar picture with scattered loosely cohesive or single cell with very hyperchromatic nucleus. And when we go on higher power, these nucleus are these cells show definitely enlarged of nucleus comparing to the adjacent inflammatory cells, high NC ratio, polymorphism, and hyperchromasia. Some of the cells show this hypochromatic pattern, but with scattered coarse chromatin. So this is also positive for high-grade urothelial carcinoma. And in the background, we can also see some necrotic cell debris as well. So this is positive for urothelial carcinoma, high grade. So let's move to some body fluid. The first specimen is ascites specimen. On low power, you can tell that the specimen is a little bit bloody. So we've seen some degenerated blood in the background, as well as a lot of these single cells. Some of the cells show eccentric nuclear and with a little bit material inside the cytoplasm that push the nucleus to the periphery of the cells. Due to these hemorrhagic background, we see a lot of reactive type of changes like vacuolating cytoplasm, enlarged nucleus, sometimes a little bit irregular with small but distinct nucleoli. So it is a little bit difficult to tell if these changes are actually reactive changes or it belongs to the spectrum of a metastatic adenocarcinoma. We do have a cell block for the specimen. In the cell block, we can see some areas show more prominent cohesive glandular pattern. So this cluster looks much more like adenocarcinoma, but it is uncertain that whether these single cell in the background are also cancer cell. So we only see two clusters of more cohesive cells, and looks like adenocarcinoma. But in the background, there were also a lot of single cells that we don't know if it's cancer or not. So we do a MOC31. So you can tell that there are more tumor cells presenting as single poorly differentiated cells than we expected. And again, the tight cluster, these are definitely adenocarcinoma. But the problem is the single cell in the background. So I would say this specimen is quite difficult because this cell is basically indistinguishable based on the cytomorphology from the adjacent histiocyte or reactive mesothelial cell. So in this scenario, immunohistochemistry is very helpful for us to confirm. So the patient had a past history of pancreas cancer. So it has already developed this poorly differentiated morphology as a single cell. So the next specimen is a new patient. He presented with some neurological symptom and sign and was confirmed to have a brain tumor. And then the patient also confirmed to have a history of lung cancer. So the brain tumor is likely metastatic from the lung primary. This is his CSF specimen. So for the CSF specimen, usually there was no cells. In this specimen, we see there are a lot of cells, some with a tight cluster, some seems to be inflammatory cells. The cluster cells has a relatively bland morphologic pattern comparing to the ascites specimen that we just see. The cell shows very smooth nuclear contour, delicate chromatin pattern. There is no nucleus, no polymorphism, no hyperchromasia. Comparing to the adjacent inflammatory cell, it only shows a slightly enlarged of nuclear. So in the CSF specimen, sometimes it's quite, I would say, paradoxical that metastatic adenocarcinoma can actually have a very, very bland morphology. But because the normal condition is no cell, you really have to check that these are actually metastatic adenocarcinoma. So for this area, this looks more convincing because of the nuclear atypia. The cell is not smooth with angulation and with variation in size. The arrangement is also disorganized because these you see overlapping and these you see a big gap between two nucleus. So this is more consistent with adenocarcinoma. The specimen was initially graded as benign inflammation by the cytotech. However, if we do TTF1, so this is a TTF1, you can see most of the cell, despite these very bland morphologic pattern, are diffusely positive for the TTF1. So this is metastatic primary lung adenocarcinoma in the CSF specimen. It is not uncommon to see this very bland morphologic pattern in the CSF metastasis. The next specimen is from an ascites. The patient had a past history of pancreatic cancer. So now we are very familiar with this morphology. So these are most likely histiocytes and some lymphocytes. But this one with eccentric nucleus and some mucin in the cytoplasm, this one is metastatic adenocarcinoma. As we know, in pancreatic cancer, sometimes the metastasis in the pleura, in the body fluid can be very, very scant. So you really need to pay attention to these like single cells with nuclear atypia or with the intracytoplasmic mucin. So again, here we see another cells with some mucin in the cytoplasm. So this is metastatic adenocarcinoma. The next specimen is coming from a 51-year-old male who has a past history of sinonasal rhabdomyosarcoma. So rhabdomyosarcoma, the cytomorphology is usually a small round cell tumor. So it is a high NC ratio cells with a little bit of cytoplasm and can has this type of morphology. Okay, so this is lymphocyte, and this one with an ovoid shape and irregular chromatin pattern and with almost no cytoplasm. So this one is rhabdomyosarcoma. So again, we see so-called small round cell with very, very high NC ratio and hyperchromasia. So these are compatible with rhabdomyosarcoma. So these are the involvement of rhabdomyosarcoma directly into leptomeningeal space, and the tumor cell is present in the CSF specimen. Okay. So we had a couple lung cancer. This one is from a pleura effusion with a patient of non-history of primary lung adenocarcinoma. So we see like cell ball, three-dimensional cell cluster arranging a glandular pattern. So this is compatible with primary lung cancer recurrence. The next one is a new patient, also pleura effusion. It's from a 74-year-old male and who presented at our emergency department. So in this specimen, we see quite some inflammation, but a lot of cell appears to be malignant and looks like adenocarcinoma. So if you take a look of the cell block preparation, so you also see that a lot of adenocarcinoma. So we will do a TTF1 to confirm that it is coming from the lung primary. So the next specimen, also coming from a patient with a non-past history of lung adenocarcinoma who has received targeted therapy. This is the cytospin preparation. Basically, we only see inflammatory cells and with a very, very scattered atypical cell cluster. So the case was initially screened as negative. However, if you go to the cell block preparation, you can also see similar component. So this one is more typical and with a traction artifact, a glandular arrangement with irregular like a polarity. So this has very, very scattered metastatic adenocarcinoma. So this is compatible with recurrence of the patient's adenocarcinoma. So sometimes in this recurrent setting, the cancer cell can be really, really scant. So it would be sometimes very difficult for you to confirm that there is metastatic cancer. So multiple different preparation sometimes can help you to tell. So for that case, in the cytospin, I think we can call it at least atypical, but for the cell block preparation, I think we can be very confident that they are adenocarcinoma. So this specimen is also coming from a pleural effusion, but the patient doesn't have lung cancer. She has pancreatic cancer. So we see very scattered but very high-grade adenocarcinoma cell with highly vacuolated cytoplasm. So this is compatible with metastatic pancreatic cancer high-grade. So back to the pleural effusion. History of primary lung cancer. This is compatible with recurrence, but most of the cell has developed this poorly differentiated single cell appearance. So in this scenario, sometimes, as what we discussed, it's quite difficult to tell if these are reactive mesothelial cell or histiocyte. However, in this case, it is very apparent that the size of the nucleus is already more than 4 or 5 times bigger than the adjacent histiocyte. So supposedly, these are all cancer cells because reactive cell cannot develop these size of the nucleus. And scatterly, you will see some of these very coarse chromatin, prominent nucleolus, and so this is compatible with metastatic adenocarcinoma, develop this poorly differentiated single cell pattern. So the next specimen is also lung cancer with a similar presentation. It is a different patient, so it is very common that we encounter this type of specimen in our practice. So let's move to some fine needle aspiration. The first one is coming from a lung nodule. So on low power, you can already tell that the background is quite dirty. And you see a lot of cellular debris in the background. Looks like a dirty necrosis pattern. So for these epithelial cells, you can see it is highly overlapping with a very prominent stratification. Almost looks like a feathering pattern that we see in the endocervical adenocarcinoma in situ. So this is just based on the morphology. It is most commonly we will see in the metastatic colon cancer. So you can see dirty necrosis and with like stratified nucleus, hyperchromatic in these like intestinal type adenocarcinoma morphology. So indeed the patient had a past history of colon cancer and it is compatible with metastatic colon cancer. The next specimen is coming from a bone aspiration. So in this specimen, we see some loosely cohesive cell cluster with definite nuclear atypia. The chromatin pattern shows this coarsely hyperchromatic pattern with irregular nuclear contour and small but tight cluster. So this is compatible with metastatic carcinoma. And the patient doesn't have a non-history, so we will probably wait for the concurrent biopsy to confirm that it is a carcinoma. Just based on the morphology, it is an old male patient. It will be a little bit difficult to tell. It can be coming from the lung though. So we will wait for the concurrent biopsy to decide if it's a metastatic carcinoma or it can be some other cancer type. Finally, a thyroid fine needle aspiration. On low power, we do see some colloid, but most of the colloid seems to be like this very dense, thick colloid. But we also see a few like a thin colloid with more like amorphous shape. So on low power, it can be compatible with benign follicular nodule disease. However, when we go to the high power, we see most of these follicular cell has nuclear feature of papillary thyroid carcinoma, and you can see that the pseudo inclusion is very apparent in these cell cluster. So this is papillary thyroid carcinoma, and the atypical cell is throughout the entire specimen, so we will be really confident to just call this TBS6. So that's all the case for today.
Thank you.
Thank you.
Hey, Dr. Nam.
Yeah.
I'm going to go to the what do you call this? The medical
Sure.
just to get access.
Yeah. Can we? Is Dr. Guo here already? Can we ask her about the case?